Please welcome Dr. Ryan Van Ramshorst, the chair of the TMA Select Committee on Medicaid, CHIP, and the Uninsured, and Dr. Carla Ortique, the vice chair for the Texas Maternal Mortality and Morbidity Task Force. The other comment I will make, there's been a lot of activity on Twitter. Please keep that up. Remember the hashtag Texas Ledge and TMA Maternal Health. We want to make sure everyone hears the great conversations that are happening today. So thank you.
So thank you so much to the leadership for the opportunity to spend a few minutes with you this morning. I don't have an objective slide, which is kind of sad as an academic physician. Basically, the take-home message for the few minutes that I have with you this morning is, what is Medicaid and why is it important to women and children, is really what I want to communicate with us this morning. So let's first look at coverage trends in the great state of Texas. So the top line is the percentage of individuals with insurance, and thankfully that line is going up. And the yellow line that you see below is the percentage of individuals in Texas which has decreased. This is all comers, all adults, all children in Texas. When you look at pregnant women, we've also seen a decrease in the percentage of women who are uninsured by about 7% looking at 2016 to 2013. So this is optimistic, this is good news. And why is this? This is because of investments in Medicaid, CHIP, the Affordable Care Act, and other similar initiatives that Texas physicians and advocates have been pushing for many, many years. So let's look at coverage in general for women in Texas. Not surprisingly, the largest chunk, the red chunk, is employer-sponsored insurance. Women, children, adults, most of them get insurance through employer-sponsored coverage. Direct purchase would be an example of purchasing something on the health insurance exchange through the Affordable Care Act. That's the yellow. Medicaid is 10% of women's coverage. Uninsured is 19%, so we have a lot of work to do. When you look nationally, about 11% of women are uninsured, so Texas is above the national average when it comes to women without insurance. And as a pediatrician, we also rank in the bottom 3 states when it comes to percentage of children who lack insurance. And I would submit to you that the coverage between mothers and children is intimately related. So Medicaid is 10% of the piece of this pie. So let's look at some risk factors for being uninsured. Not surprisingly, being at or below the federal poverty level is a risk factor for lacking insurance. Being a single parent, having less than high school education, being African American, Hispanic, and not surprisingly being a non-citizen are risk factors for lacking insurance in Texas and in the United States. And this is data from the Kaiser Family Foundation, which if I could give you one resource to learn more about coverage trends in general and Medicaid specifically, it would be the Kaiser Family Foundation. And these are risk factors that we saw Dr. Ollier speak about earlier this morning in terms of what contributes to maternal morbidity and mortality. And the people in this audience know that coverage and access is intimately related to those issues. So let's look at Medicaid in general in Texas. So again, as a pediatrician, Medicaid is the single largest insurer of kids in Texas and in the United States. Medicaid in Texas is largely a program of low-income children. Poor parents make up 4% of the Medicaid population, amounting to about 150,000 individuals. Pregnant women are 3% of the Medicaid population, amounting to about 139,000 individuals. And then the next biggest chunk in Medicaid is aged and disabled, including disabled children, children in the foster care system. Let's look at who Medicaid covers. On the far left of this diagram, you see pregnant women and infants, infants defined as children being less than 1 year of age. The blue bar represents the minimum amount of cover that's in federal statute. So this is what the federal government says, Texas, you must cover individuals in this category up to 133% of federal poverty. Texas actually provides more generous coverage through its Medicaid program to pregnant women and infants, almost up to 200% of federal poverty. Way to go, Texas. Unfortunately, as an example, this is at risk. During the last legislative session, it was a difficult budget cycle, and I remember providing testimony to the Senate Finance Committee, pleading with our elected officials not to get rid of that optional coverage, taking it up to 200%. And I'll conclude with some remarks about being advocates for our patients and why that's important. The other category I want to point out is the middle category. So if you are a single parent and you make more than $3,000 a year, you don't qualify for Medicaid. You'll also notice on this graph that able-bodied working adults who are not parents do not qualify for Medicaid in Texas because Texas elected not to expand Medicaid as part of the Affordable Care Act. But again, making more than $3,000 a year as a single parent and you don't qualify, and again, we know that if parents are insured, kids are insured. So let's look a little bit more about who Medicaid helps. 4 million Texans depend on Medicaid, 1 in 7. Most recipients live at or below federal poverty, which is not surprising. Medicaid was designed to help those most in need. Most recipients are young. Again, Medicaid is a program largely of low-income children in the state and nationwide. Most recipients are female, and as we've discussed before this morning, Medicaid pays for over half of births in Texas. And there's been lots of conversation over the past few legislative cycles about mental health, about postpartum depression. Medicaid is the single largest provider of behavioral health care in the state, and this includes comprehensive substance abuse and mental health treatment for pregnant women. Who doesn't Medicaid cover? So it's not available to all poor or low-income women, as I've elucidated from the prior slide. You have to have limited income and qualify categorically. And pregnant women lose that Medicaid benefit 60 days postpartum unless they qualify because of their income. Again, that $3,000 figure for a single parent. If they make more than that, their Medicaid drops off after 60 days postpartum. And there are some other safety net programs that they transition to, which I'll mention briefly in a few slides. Populations not covered. Again, healthy, childless adults, able-bodied working adults. Texas elected not to find a Texas solution to expand Medicaid. Again, if you're a parent earning more than about $3,000 or $4,000 a year, you don't qualify for Medicaid. If you're undocumented, you do not qualify for Medicaid unless it's emergency Medicaid, which is beyond the scope of our conversation. Legal immigrants do not qualify for Medicaid in Texas, although other states have found ways to do this. Why does Medicaid matter? So Medicaid is key to improving women's health and addressing our alarmingly high rate of maternal mortality and morbidity. Again, over half of births are covered by Medicaid. 42% of pregnant women on Medicaid are between the ages of 19 and 24, so these are young mothers. And we know that Medicaid provides preventive, prenatal, and postpartum care. And then we have these other programs, Healthy Texas Women and the Family Planning Program, which I'll speak on briefly. And for uninsured low-income women, Medicaid also provides a breast and cervical cancer screening and treatment option. So CHIP Perinatal. You've heard of CHIP, the Children's Health Insurance Program, enacted in 1997 to cover children that lived in families with incomes too much to qualify for Medicaid. In 2005, Texas established the CHIP-P, or CHIP Perinatal Program, which provides what I consider to be very limited benefits to uninsured low-income women who don't qualify for Medicaid because of income or immigration status. And really, this is coverage for the fetus. This is not coverage for the mother. I was speaking to medical students yesterday afternoon, and they really had a hard time understanding the concept that this is coverage for the fetus, and they said, why wouldn't you cover the mother? And I said, that's a really great question. But I'm glad that we have CHIP Perinatal. To qualify, you must be at or below 200% of federal poverty level. For a family of 4, that's about $45,000, and you must be a Texas resident. So the benefits, I'll let you read the slide. Prenatal visits, prenatal vitamins, prescription drugs, lab testing, labor and delivery, and 2 postpartum visits, and that's it. And you can see that there are services that are excluded. And something else that's important that's going to come up during our reference committee hearing is that CHIP perinatal enrollees are not automatically transferred or auto-enrolled into the other safety net programs. So not surprisingly, there's a drop-off. Okay, there's 2 preventive health women's programs that are operated in Texas that are entirely state-funded. Healthy Texas Women, known as HTW, and the Family Planning Program. So HTW, again, it's state-funded, and it's a limited benefit program. This is not technically insurance, which is why it wasn't included on the earlier slides. To qualify, a woman must be uninsured, not pregnant, and be low income. There's an age restriction between 15 to 44, and you must be a Texas resident and a U.S. citizen or legal immigrant. And there is auto-enrollment between Medicaid and Healthy Texas Women, which is wonderful and a great idea, but I'll tell you that in practice, this isn't always happening. So again, there's a drop-off of women that had Medicaid postpartum and then not actually getting enrolled in HTW. And there are benefits, but what I will mention is if you identify a mother with postpartum depression that needs specialty care, it's not covered through HTW. Family planning is similar to HTW in that it is state-funded. You can see the eligibility there, and it's also a relatively limited benefit package, even more limited than HTW. But I'm thankful that we have it and we can offer this to women. I want to thank Healthy Futures of Texas and the Texas Women's Healthcare Coalition for these slides. You can see on the slide the women's health programs that I just mentioned, and then that big red bar is the women that are not being served that are in need. So lots of work to do, and we in this room have the power to do that. I'm not going to spend a lot of time on this slide. You've seen this before. It's the same barriers, the same risk factors over and over again. The number one reason being that women cannot simply pay for these services because they're expensive. And if you don't have an insurance program to help cover that, it's tremendously difficult. So thanks again to Dr. Riolini's leadership and her help with these slides. So 1.8 million Texas women are in need but don't have access. And Medicaid matters to women and families. We know that the rate of uninsured and uncompensated care decreases, patient access increases. Medicaid is key to addressing social determinants of health, which was brought up in a question earlier. As Medicaid transitions to a value-based care space, there will be opportunity to help address social determinants of health and not just fee-for-service. And Medicaid has outcomes that impact things in addition to health, decreases financial hardship, improves educational outcomes for kids with Medicaid, and it increases future tax payments by individuals, which is an important thing to mention. As I mentioned before, there will be opportunity through value-based payment schemes to help address social determinants of health. I'm tremendously optimistic about that, but I think there's going to be some kinks in working this out. I'm going to stop there and transition to Dr. Ortique.
Good morning, and thanks again for your attention this morning. I really appreciate the opportunity to present. My topic this morning is the impact of race and bias on maternal health, dying to be a mom. I don't have any financial disclosures, and my only conflict of interest is that I'm an African-American woman. I'm a black girl who rocks. These are my objectives. I'm not going to read through them. Hopefully we'll achieve them. We're going to start off with a personal story. This is my granddaughter, and I pray, is a black girl who rocks. She's in school at UT right now, and so we're staying in prayer for her. But in 1999, my daughter-in-law, who's a UT grad, married my stepson, or was married to my stepson, an A&M grad, so we got it both ways. Anyway, she spent 4 days in the intensive care unit following the delivery of our granddaughter in Austin. She had had a severe form of preeclampsia that was misdiagnosed, and I do mean the diagnosis was missed. She had seen her healthcare provider on Thursday with complaints of mild shortness of breath and some swelling. She was identified as having mildly elevated blood pressure and mildly elevated liver function test. She was advised to go home and rest over the weekend and to come in on Monday for a recheck. She came by our house on Friday for a visit, which was typical, and she looked like the Pillsbury Doughboy. At that point, she told, I asked her, well, have you seen your doctor? And she told me what they said, and when I heard liver function test, I was like, well, how about we run over to the ER and just check things out? We went to the ER at a hospital just up the street, and her transaminases were above 500. So for the OBs in the house, you know what she had. She was admitted and delivered by C-section and then spent 4 days in the ICU while we played with our beautiful granddaughter. The quote that you see there is one of my favorites regarding maternal health. Women are not dying because the diseases cannot be prevented, but because the societies have not made the decision that their lives are worth saving. This was said at the UN in 2006, and it was referring to developing nations at that time. And yet, here we are in 2018 in a state where those words definitely apply. We've already talked about the mortality rate in Texas, which in 2014 was 31.5 per 100,000 live births. African American women bear the greatest risk, as this slide, I think it was in the earlier presentations as well, shows, at at approximately 3 times the rate of white women in the state. So what's driving this inequity? That's what we need to figure out. Are the number of births to black women increasing? No, we're staying pretty steady at 11% of the births over the last decade. So it's not that we're increasing in births. We've talked about the higher burden of chronic diseases and the slide, so I'm not going to spend much time on these. They do show that for all mothers, chronic diseases are increasing over time. White mothers, Hispanic mothers, as well as black mothers. They are increasing among black mothers at a little bit faster pace, though. So we know, though, that controlling for these comorbidities, and I'll present some data about that later, does not eliminate the inequity. So what else is there? We talked about low socioeconomic status. We've talked about lower education as possibly increasing maternal death. But when we control for those factors, the disparity still exists, or the inequity. And I'm going to try and use the word inequity because it lacks the negative connotation for the black woman. So maybe we're just biologically different. Maybe genetically we're different. But every scientist in the room knows that the Genome Project has determined that we're 97 to 99% the same. So that is not the answer. I would submit that the Middle Passage, 256 years of slavery, has created a slave health deficit. That's a term that was coined by one of the presidents of the National Medical Association. Greater than 2 centuries of inhumane living conditions, poor nutrition, cruel and unusual punishments, medical and surgical experimentation, breeding, inbreeding, and other unmentionable atrocities has created a higher incidence of certain disease states in black Americans when compared to black Africans. Following this, the codification of bias and stereotype by Jim Crow laws in our country has created, and those Jim Crow laws were in existence until the early 1960s. They created a residential and education segregation that continues to exist today. The resulting healthy food, quality education, and quality healthcare deserts that were created by this segregation continues to negatively impact health incomes for black Americans. Examples of bias and stereotypes are in the news every day. The discriminatory lending practices, criminal law enforcement practices, housing discrimination continues to exist. The serving of fried chicken, greens, watermelon-flavored drinks, and Kool-Aid at NYU just last month during Black History, which actually should be American history, is a recent example of stereotyping. All of this has created institutional and societal racism. I call that a cortisol effect, or living while black. But I don't have the data, so I'm going to tell you about the people who have the data. Geronimus in 1996 identified that racism may operate along a stress pathway to negatively influence the reproductive outcomes of black women long before they conceive. Chronic exposure to racial prejudice and discrimination could trigger adaptational responses that over time contribute to physiologic wear and tear, which has been termed weathering, or getting older before your time. So maybe black women are AMA at 30 as opposed to 35. We need research into this to try to figure out if this is what's going on. I'm not going to read the quotes that are listed there. You can read them yourselves. But the book in the middle is near and dear to my heart. The Negro Motorist Green Book is the book that guided our travels as a child from Chicago to New Orleans, where my father was originally born. We went the exact same route every time. We ate the exact same food in the car every time. We stopped at the same gas stations. We stayed at the Lorraine Motel in Memphis every time. I spent time thinking that my parents were really mean, because in Chicago, I didn't stay in a motel. If we went out, we could stay in a hotel that was nicer. And in Chicago, we went to restaurants that had good food, and we didn't eat in our car. And so I really didn't understand why I had to do this every summer. It wasn't until later that I understood that we stayed where we did and we ate what we did because that's what we initially were allowed to do, and later that's what was safest for us to do. So how does this impact maternal health? Alexander and her colleagues identified that Black women are less likely to enter prenatal care in the first trimester. They're less likely to receive adequate care, and they generally receive lower quality care even when access and insurance coverage exist. This was borne out in our Texas data as well. The largest determinants of entry to prenatal care were Medicaid, which is a proxy for socioeconomic status, being Black, and having an unintended pregnancy. So the Black-white maternal mortality disparity is the largest among all conventional perinatal health disparities. Black women consistently experience 4 times greater risk of pregnancy-related death than white women. This is independent of age, parity, or education. Black women are more likely to die from complications of hemorrhage, hypertensive disorders, and cardiomyopathy. Our data in Texas does bear this out as well. National data sets revealed that Black women do not have a statistically significant greater prevalence of preeclampsia, eclampsia, placental abruption, or previa than white women, but they're 2 to 3 times more likely to die from these things. A comparative review of maternal morbidity and mortality at the hospital level allowed stratification of high and low performing hospitals. Hall and her colleagues in New York reviewed claims data on 40 hospitals in New York City, representing over 350,000 deliveries between 2011 and 2013, and had the following findings: that severe morbidity was 2.5% higher in Blacks than whites. It remains statistically significantly higher even when controlled for patient characteristics as well as comorbidities. And 65% of white mothers versus 23% of Black mothers delivered at low morbidity or high-performing hospitals. The study estimates that as much as 47% of the racial disparity may be attributable to delivery location. In their Girl Interrupted study, the Georgetown Law Center on Poverty and Inequality anonymously surveyed participants and found that the following reported beliefs existed, and this was about Black girls aged 5 to 15, that they needed less protection, less support, and less comfort, that they were more independent and knew more about adult topics and sex. Green, Alexander, and others looked to answer the question of whether implicit bias impacted recommendations regarding thrombolysis in acute cardiac patients, using questionnaires to identify explicit or overt bias, and then implicit association tests to identify the unintended biases. They tested 287 ER residents in Atlanta and Boston. They found no explicit bias reported for whites versus Black, but they did identify that implicit preference for treating whites and stereotypes regarding noncompliance and uncooperativeness of Blacks were identified. The impact of racism and bias include fear of mistreatment, lack of trust, lower self-esteem, and internalized racism. Focus groups in Houston that were funded by the Houston Endowment Fund identified that Black women felt that their physicians did not look them in the eye, they didn't touch them at times, so I didn't know how you got examined without being touched. But they felt like they were less than human, and that often drove them not to continue care or not to participate in postpartum care. It's clear that both individual and institutionalized racism and bias continue to contribute to the racial inequity seen in maternal health. And until we address these issues, the inequities will persist. And that's why I'm so happy that we're talking about it today. But why should we care? Aside from the ethical and moral reasons that we as physicians are pledged to, It's economically imperative to address these issues. According to the Joint Center for Political and Economic Studies, racial and ethnic disparities cost Americans $1.24 trillion between 2003 and 2006 and continue to cost over $300 million per year. So what can we do? Let's start by reviewing some basic definitions as we seek to arm ourselves with tools that can make a difference. Cultural knowledge is familiarization with selected cultural characteristics, history, values, and belief systems of members of another ethnic group. Cultural sensitivity is better than cultural knowledge because it's not assigning values to those differences. And the golden fleece, if you will, cultural competence. Integrating knowledge about individuals and groups of people into specific standards in appropriate cultural settings to increase healthcare quality and improve health outcomes. To consider what we can do, let's look at data from a state that I am going to mention the name, Dr. Ollier, that has seen its maternal mortality rate decline over the same period of time that ours has risen. California identified in 2005 that their maternal mortality rate was significantly rising. And so they began to investigate what was driving the rise. And through review of state mortality cases and data-driven implementation of evidence-based standardized protocols in over 200 of their hospitals, they saw a statistically significant decline in maternal mortality rates. As you can see, this is compared to the US, and this is compared to Texas. I want you to notice that our rates were almost exactly the same between 2005 and 2006, and it was the careful study and implementation of protocols that allowed them to see their rates fall. I'm really excited about that. And the reason being that the fall was in African American women. If you look at their data closely, there really wasn't much change in the rates for any of the other ethnic groups or for white women. The change has been among African American women, and so that gives me great hope that the changes that we are going to institute as a result of meetings like this are going to make a difference for our people, for my people, for all of our people. But why is the white hot media spotlight on Texas mortality rate right now? Well, it's because between Texas and California, we account for over 20% of the deliveries in this country. And so if we can lower the mortality rate in Texas, we can lower the mortality rate in our country. And I'm going to be finishing soon, for sure. So what can we do collectively? We can read the slide and go through all the proposed solutions, and I think many of them are covered in the proposals that so many of our stakeholders have submitted for our consideration later. But I will mention using thorough review of maternal mortality and morbidity cases with an emphasis on race-related as well as socioeconomic determinants to help guide how we implement our changes. That's self-serving. I am on the task force. Using available geomapping data on disparities to focus public health campaigns. And then my last plea, you know, we have the right to bear arms, we have the right to free speech, we have the right to vote. These are all codified by either our Constitution or our amendments. We need to advocate for the right to have universal access to health care. Until it's a right, it will remain a privilege for those who can afford it. Individually, I'd ask that we stop blaming the victim. It's not our fault. We can't help it. We're going to try and make a difference, but stop blaming the victim. Stop denying that there's an existence of implicit bias based on race, socioeconomic status, and gender. Look your patient in the eye. Look for opportunities to empower them. Look for evidence-based practice. Listen with empathy and without judgment. I encourage each of us to take an implicit association test to determine what biases we have, because we all have them. I think that men are less compliant with medical treatment than women, and that's why I'm no longer a family physician and I'm an OB-GYN, because my bias kept getting in the way. Ask some questions and have some conversations about race. It can be uncomfortable, but it's worth it. In closing, I think that Gandhi said it best. Let's all be the change that you want the world to see. This is my niece standing in front of one of our symbols, one of this country's symbols of liberty and justice for all. I'm so grateful that Dr. Cadenas and the TMA, that DSHS, the Texas Maternity and Mortality Task Force, that the Texas Collaborative for Healthy Mothers and Babies, and all of the stakeholders present have taken the time to address this healthcare crisis. My niece and my granddaughter's lives depend on us making a change. Thank you.
Well, thank you again, Carla and Ryan, for a great presentation and the disparities and the challenges and access and the role of racism plays in this issue. We're running a little bit tight, but I do want to take a little bit of time if there's some questions for our presenters. And please come up to the microphones so that everyone can hear your question. Yes.
I want to thank Carla for a wonderful presentation. I think you've introduced a term that needs to be popularized, this institutional effect of cortisol. Because if you look at that and you look at the ACEs, you're going down the same pathway with the same results. And if you look at the American Indian and reservations or any other place where your cortisol is going to be running high, I think you're going to see the same result.
Thank you, Les.
Thank you.
Any comments before we go to the next presenter? No, but thank you.
No, I would just say that by calling it the cortisol effect, it takes away the sting when you talk to your patients. It's not, yes, we know that exercise, losing weight, treating hypertension, doing all of those things is important, but it's also important to empower women and to help them understand that there are some things over which they don't have control.
Okay. George.
So I have two comments or questions if you want. One for Chip, about Chip. The chip doesn't cover testing that would help the mother. So like if we want an echocardiogram on the mother, it's not covered. If we want to do anything to prevent mortality and morbidity in the mother, chip would not cover that. So that's about chip. And then I have a comment to Dr. Ortique. Thank you very much. And thank you for providing the solutions. All great, and I agree with them. But I'd like to add one more to your solutions. In oncology, health disparity in oncology has been studied extensively. And one of the interventions that helped with that was patient navigators. And there is good evidence that it helped. And I suggest that one of the solutions to this problem in obstetrics is patient navigators.
So let's go through those in order. And Ryan, the first one, the role of CHIP and paying for the rest of these medical tests that are needed.
So I see a very similar issue in my practice. I co-medical direct a teen clinic, and as the people in this audience are aware, CHIP does not cover contraception. So it's definitely like Swiss cheese. There's lots of holes in the CHIP coverage, and I just think what I'd say is that's just an opportunity for TMA to get out there and all of the other advocacy groups represented here today and say this, we can make this better. My other comment is that one of the reasons why states tend to like CHIP more than Medicaid is it has this enhanced flexibility to where states can decide, I don't want to cover contraception in my CHIP program. And I think there's an opportunity for us there to kind of push back against that and say we still need to provide the best coverage that we can. But thank you for the comment.
And Carla, the question related to the role of navigators and how that could be helpful or not related to this issue.
I would just say, I agree.
So the comment was, I agree.
Yes.
So yes. Over here.
Hi, I'm Donna Kreutzer with Pregnancy and Postpartum Health Alliance of Texas. And I just wanted to make a comment, Dr. Ortique. I was at the delivery, death by delivery on February 20th, where you were a panelist. And I just want to let you know, and I think it's worthy of everybody else here in the audience hearing, that as you remember at the end, I was asked to speak by Representative Theory, and I addressed the fact that the Rice students in the audience could come to my home when they came to Austin. I want y'all to know that there were 11 Rice students in my home on March 16th, and they are ready to tackle whatever we can to bring the disparity to the Black deaths and the maternal mortality rate, and to learn as much as they possibly can in policy and advocacy, and to learn as much as they can on postpartum depression awareness. And they have written to me several times since, still stating that they are all ready to do whatever they can. These are 11 Rice students that spent their entire spring break touring around Austin, speaking to hospitals, other organizations and such, to help us help women. So thank you again.
Thank you. Barry, last comment?
I just want to
Oh,
thank
okay,
you.
yeah.
Thank you for your courage. She's being modest and not sharing her story at the moment, but we thank you for your advocacy and are with you.
Thank you.
I want to bring some other facts and observations related to the disparities, and particularly to Texas. Dallas is the #1 city in the country, according to the Urban Institute, in neighborhood income inequality. Houston is #3. Austin is in the top 10. We clearly have an issue that we've created in this state that creates ghettos and places where we lock people into poverty. Encourage everybody to read Richard Rothstein's book about how the United States systematically segregated this country through the development of its suburbs and how that's affected us, and do your observations about the places that you live to see how that's operative in Texas. And then finally, it's not just about health care, it's about housing, and housing and the environment has an effect on people. And looking at that, the book Evicted, about how that creates disparities by making people virtually homeless and moving it around, particularly moving experience. I found that one particularly compelling for me because I practiced in that neighborhood in Milwaukee that most of the book is written about. And I felt, I alternately between chapters cried and was enraged. Mm-hmm. So I encourage you to think more broadly as well, but we got to address some of these issues for women.
Thank you, Barry. And maybe a short comment before we get to the last question.
I would just say we totally agree, and I was running through, the topic is really an hour presentation, but housing is critical. If you don't have safe places to exercise, you can't let your kids out and play, you can't walk in your neighborhood. All of these things are critical, and it still goes on today. African Americans are steered towards less desirable neighborhoods by realtors. There are studies on this. I would add to your reading list the Brookings Institute recently published a paper on big ideas for change. It has a great deal of information along those lines.
Okay, great.
For rental housing, we now have in Dallas the toughest housing code in the country, passed by a 13-1 vote by our city council. The one person who voted against it said the changes weren't tough enough. We did that through a coalition between healthcare folks and folks from communities speaking up for themselves and making that change happen.
Thank you, Barry. Charlotta? Dr. Guillory?
2 quick things. One, first of all, Thanks for a great presentation, both of you. I want to ask Carla, number one, in terms of California, what was it the bundle that you showed of all the solutions? What were the main things that affected the outcome there? And secondly, it's just a quick comment. Thank you. As an African-American female, when I first started my fellowship at Texas Children's Hospital, I recognized that we were 12% of the population. But it didn't take long for me to look around the neonatal intensive care unit and see the number of African-American babies we were dealing with. So my interest was there for a long time. And from that day still to today, we're talking about the same thing. So thank you for the work that you're doing. Thank you all for trying to make a difference, because it's very hard to look into a patient's eyes and tell them we're doing everything possible when we're losing babies every day for no reason. And I just want to say I had an opportunity to work with Dr. Kay Bartholomew when I did an MPH at University of Texas. And she worked with us on the high rate of premature births in the African American community in Houston. The first thing she did was Dr. Sade said, and we worked with getting a navigator to navigate our mothers through the system. The second, of course, was fresh fruit and vegetables, dealing with obesity, stress and how to decrease that, and that was through exercise. We all know that. But the other thing, and I think you hit on it, was the fact that a lot of times the cultural competency and the way we look and treat our patients was critical. So even when, the studies show when you saw African American women who were doctors still had a high rate of infant mortality. So what's different there, and how do we work with that? So I just want to thank you guys again. No.
Thank you, Dr. Guillory, for making this real. Dr. Ortique, there was the question early on related to California and the work that they had done.
My understanding is that, and we've had presentations from Dr. Elliott Main when our task force was initially constituted, which was just in 2013. And so I really, I'm a glass half full kind of person. I want us to be excited because we can make a difference. But what they said was that once they identified that hemorrhage and hypertension were among the leading cause of deaths, they implemented standardized practices and protocols in their hospitals, and they had over 200 hospitals. So they're a large state similar to ours. That's why we often use their data to compare they have the wide diversity as well. And they implemented the bundles, and they began to see things come down. They've continued to create standardized protocols. They've just released a toolkit on cardiovascular disease, and so we're hopeful that will become another one that we can implement here within the state of Texas. But by using their data to figure out, what's causing the deaths, they came up with standardized protocols that allowed for better outcomes among their patients.
So please join me in thanking our speakers, Dr. Ramshorst and Dr. Teague.